Thank you, and welcome to the final hour of the initial part of our conference, the presentation of evidence, and the many wonderful questions that have been asked. Before we get started on this final segment, we received an email this weekend from Dr. Danusia Kanichowski, a palliative care physician based in the Yukon. Her team, who's very interested in our work, was unable to join us in person in Ottawa, but she wanted to express to all the delegates here that palliative care matters to those living in Canada's north. Yesterday, she sent us a short video clip from Whitehorse, which we will share with you right now. And all of her colleagues are actually watching us right now online. So on behalf of everybody, we want to say thank you and welcome to the conference virtually. That was fantastic. And we're sharing that broadly, and for the record, we're hoping that you've started something, and we might see some similar sentiments from across the country. So thank you again. That means an awful lot. So for this final segment, Dawn and I have been speaking, and we've agreed that we're going to start with some questions other than from the lay panel at any time. If lay panel members want to ask questions, obviously we'll work those in. But we've received a number of questions through the online webcast and also through other means, so external questions. And to begin, we're going to deal with two questions from the podcast, and for that I'm going to turn to Carleen Bernice.
Thanks, Fred. We've had quite a few comments related to the importance of the interdisciplinary teams, their educational needs, and I bring forward a question from Catherine Amon from Ottawa. Thank you for the amazing group of speakers. It was great to see such a wonderful attention to palliative care. Can you please comment on the role of volunteers and allied health in an integrated palliative care program?
Can we ask the expert panel to self-select one expert to start that off? That's a very good question. The microphone right there, if you would.
Okay, I'm so grateful we got this question about volunteers, because as I was thinking about the pieces that we missed, I was thinking, this is just an incredibly important part of what we do. I think we know they play an incredibly valuable role. I think we need to think very, very carefully in healthcare what it is that we do well within paid healthcare and what it is that we do not so well and other people perhaps do better. And I think in my research, particularly in rural communities and within hospice societies across Western Canada, what I have found is that the quality of care goes up dramatically with the systems that are closely linked to the volunteer systems as well. They have very robust training standards in Canada, both at the national level and at the provincial level. And I think if I could put in kind of one plug perhaps is that, the larger hospice societies tend to have quite a bit of capacity. There are many, many smaller hospice societies that do this work throughout the country in the smaller communities who are constantly having to scrape together resources even to do volunteer training. And in some places I've done research, they've been linked very, very closely with the paid healthcare team, and the care just is so much better in that capacity. In other communities I've been in, you have this marvelous hospice capacity waiting to help, and there's very little uptake of it, and they get called in perhaps too late to do the good work that they do. So I do think we need to think more carefully about this aspect.
Thank you. Carleen, another question from the podcast?
This question is from Julie Drury, also from Ottawa. She asked this question yesterday when Dr. Brazil was talking, and also repeated a similar question when Dr. Williams was talking. Parents of children may provide care for many, many years, impacting physical, social, and financial their own care. Can you please comment on how parents can be supported in an integrated system?
Okay. Dr. Brazil or Dr. Williams or anyone else who'd care to comment?
I think over the last 2 days, we've been hearing specifically about the importance of the critical role that family carers play. And also we've heard the importance of supporting family carers with respect to the responsibilities they have. Specifically, we've heard, I think, and I'm looking at Allison here, is the notion of training and education. And I think you were using the midwifery model as well. So I think there is a recognition in terms of first recognizing the valuable role that family carers have, the essential role, and also I think there's a recognition in the discussions we've had in terms of finding the right ingredients to support family carers with those responsibilities. So I think that's been thematically what I've been listening to. And,
Yes, and just to add to that, if I may, is the recognition that you know, the ideal of palliative care is supposed to be encompassing the primary caregiver as well as the family unit more holistically. And I think we tend to forget that. And I think if we are going to use the integrated approach, we have to be cognizant of being sure to be inclusive of the caregiver and the family as a whole, while also recognizing that the family caregiver often knows a whole lot more than anyone else in the on the landscape of any particular unit. We spoke earlier today about measures and indicators and evaluators. And certainly not that I'm biased or anything, but wouldn't it be wonderful if we had the caregivers doing that kind of measurement and that kind of quality control and feeding that data back? Because really at the end of the day, they're the ones that really know how it all went. Thank you.
Thank you both.
Could I just supplement that?
Absolutely.
On listening, just on a moment of reflection, I was thinking that in many respects, certainly what I've witnessed is, with respect to the caregiving experience, is that family carers can actually refuse help. And they say, I'm doing all right. So in many respects, what's really important is sort of the importance of an ongoing relationship between the family care and the healthcare provider. And it's this idea of recognizing transition. Because one day you may approach the family care offering help, and they'll refuse it because they see it as their responsibility and role, and then sometimes they see it as preservation of dignity of the care recipient. But then the next day, you can make that offer, and they'll accept. So there has to be an ongoing monitoring and an ongoing relationship between the formal care and informal care system so that you can insert care or supports at the right time. Yeah.
Thank you very much. So we're going to take 2 questions next from microphone number 1, and then we're going to go back to the podcast. Anya Humphrey, a member of our steering committee.
Hi. In the discussions of the Canadian Reference Working Group, as we looked at dividing up the territory into these particular questions, there was discussion about the need to have patients and families involved at every level of health care, not just giving feedback, but also participating in the design and delivery of care, and maybe even separating that out as a separate area to be discussed. And the consensus was that, well, that should be an underlying principle for all of our endeavors. And I'm a patient and family advisor, so that matters a lot to me, and I haven't heard that stated per se. So without implying that I wish to sway the panel particularly, I just want to flag that some of us feel that that's mandatory in palliative care, that we're the ones who know where the gaps are, we're the ones who know what we want, and you need us at every level. So I'd be happy to hear anything that the panel has, or the experts have to say about that, but I just wanted to raise that point in a public way.
Thank you. I'm seeing a collective nodding of heads in affirmation from the expert panel. Go ahead, please.
Good afternoon. I'm Shelley Corey. I'm the Executive Director for the Canadian Virtual Hospice, and I want to respectfully acknowledge that I'm standing on the traditional territory of the Algonquin people. the intellectual capacity in this room is really only exceeded by everybody's passion to move palliative care forward, and it's making this such an exciting 2 days. So thank you to the organizers. Really appreciate that our videos have been used to enhance this day, and I need to pay tribute to the 72 people from across the country who shared their stories. They were incredibly courageous. So if you go on to livingmyculture.ca, you will see 64 people from 11 different cultures speaking in 11 different languages about advanced illness, palliative, and end-of-life care. If you go to mygrief.ca, you'll see Amy and Mishi, who you saw earlier, speaking about their experience, as well as, I believe, about 26 other storytellers from diverse cultures and experiences. And really, they're the heroes in the projects that we have developed. And I have to acknowledge Canadian Partnership Against Cancer, because had they not stepped up to fund these projects, they would not exist. So I do have a question in all this as well, and it's for Dr. Morrison. We absolutely support research and the important investments in research and in clinical pieces, but when you were doing your literature reviews, did you find innovative models for funding innovation that isn't coming from research, that may be knowledge translation tools that are weaving research in? But I think that there's a lot of clinical programs. Thunder Bay is a good example with their tablets. Virtual hospice is another. There's lots of NGOs out there who have creative programming, but they don't necessarily fit in traditional funding models. So was there anything in these other countries that you saw that we could maybe model something innovative in Canada to fund innovation from NGOs and other organizations?
It's a very good question, and the answer to date is no, but that shouldn't be the right answer. I think all of us who are in the academic research community have recognized pretty dramatically, particularly over the past, I would say, decade, about the inexcusable delay between both research findings and integration into practice, and in some ways, more importantly, the artificial climate that we often create for our clinical studies, which actually doesn't map into the real world. So I think, in answer to your question, there is clearly a role in research for the traditional randomized controlled clinical trial. Certainly in a lot of the pharmacology work that we do in terms of drug development, there's just no better way of finding that answers. In health services research, however, I think we need to be very open to different ways of evaluation. I think we have to be open to pragmatic trials. I think we have to be very open to mixed methods, which we haven't been doing well before. And I think given the wealth of observational data that we now have within administrative data sets, we have to be very open to other statistical means of controlling for confounding. And I think we really need to be aware that there are other ways of getting at that answer besides a controlled clinical trial. That being said, I think we have to be very clear that the work that we're doing has to be rigorous, because the downside or the risks or the unintended consequences of saying this worked really well, let's just pick it up and move it somewhere else, I think is not a good use of our public dollars. Let me phrase it that way. So I think that we need to think about innovative models. We think we need to be, obviously we need to think about how we scale them, but we need to rigorously evaluate them before we put them out into general practice.
Thank you. And just before we go to microphone 2 again, Carlene, can I go back to you, please, for any other questions? Not at this time? Okay, it's fine. So we'll go to Dr. David Henderson, Canadian Society for Palliative Care Physicians, also a member of the steering committee.
Thank you very much. My question is actually comes from some of the work we've been doing. Initially, we were thinking that opening up the Canada Health Act might be, part of the strategy to move this forward. But I must say, I'm rethinking that a little bit. I've had some conversations with different people that have made me start to wonder about that. I tend to be an impatient person, and we all know we're into that curve now of what some of us call the silver tsunami, that I worry a little bit about the process that we go through and potentially not doing things that may bog down some of the process, unfortunately, through bureaucratic and political reasons. Someone I was speaking to said, should we, as opposed to opening up the Health Act, should we not just look at the Health Act and see what already exists within it that we use as our rationale for moving all this forward? And I'm certainly no expert in the Canada Health Act, but I'd like to know other people's ideas around that, because I think that's a big kettle of fish we're going to get into if we are going after opening up the Canada Health Act.
Any of our experts like to comment? Please, go ahead.
I think when I was talking the other day, it was yesterday, seems like a lifetime ago, it was I described the Canada Health Act as creaky. And I am not an expert on the Canada Health Act, but I do know the complications and the jurisdictional mess of the black box that would open up in terms of reforming it. What I do know is that it was premised on an acute care model. And I think where we are now is we operate within a chronic care model. And I think that it does need to be addressed and aligned to reflect the reality of how we care for people in this country. And how the ways and means of going about that, I'm not sure, but I think it does need to be addressed somewhere along the line, but not at the expense of holding back reform. Yeah.
Okay. Thank you. So I'll take the next question from microphone number 2, and then we'll come back. Oh, I'm sorry, Dr. Williams, did you want to chime in?
Just to add one more small point, and that is if we were to go in that direction, I think it would be really important to incorporate a public health upstream, preventative, proactive, thinking forward model of care, rather than, again, the Band-Aid kind of management acute response. Thank you.
Okay, thanks.
Ray Pennings with Cardis. My question's for Dr. Morrison. The premise of the question, I realize as I'm thinking about it, is an assumption I'm making that I'm not sure has been explicit, but that is that the outcome of the recommendation of this conference is going to be sort of a manifesto, a document that has government as its focus in terms of its audience, with the assumption of government needs to do A, B, C, whatever it is in terms of implementation. And I guess I hearken back to the very first slide we saw yesterday morning from Ipsos Reid, in which healthcare was or palliative care and healthcare was in the middle of 20 some odd percent. There was the economy at 40 some odd, and then there was a cluster of issues. And I also think of the many previous attempts, not unlike this, obviously not in this format of terms of calling for palliative care, and here we are, 2005, 2010, 2015. Is this going to be another in a series, or is this going to be transformative and be something that achieves some of the stuff that you highlighted in your in the exemplar countries that you pointed out? And I'm wondering, I was thinking as I was listening to the difference between a gesture and a posture. A gesture is an intentional movement, and often we ask for gestures, but really the solution of everything that I've heard in the last 2 days requires a change in the Canadian posture. And I'm not sure that there's any one institution, let alone government, that can achieve it. And so I guess my question is, to what extent does this need, whatever actions happen at the top, be a bottoms-up sort of thing in which business, all the different institutions that are mentioned, have to be part of concurrently, not one following the other or a consequence of the other, but concurrently in terms of really achieving meaningful culture change?
So let me begin to tackle that, and I'm actually going to put, rather than what I truly believe is that this is a moral good. I'm actually going to put a policy hat on. And I'm going to argue that as a nation here and down south, we can't afford not to. And let me articulate that further. The population that we're talking about right now, it's about 5 to 10% of the Canadian population. That's driving probably close to 2/3 of healthcare costs right now. And that number is going to increase dramatically over the next 10 to 15 years. And if you plot that healthcare spending curve all the way out, I would suggest that the increasing costs of caring for this population the way we do it now is probably the greatest single threat to our quality of life. Because either we're going to have to bend that cost curve fairly dramatically, or monies for education, schools, roads are going to have to be going into that. So from a policy perspective, it is not just about making recommendations for government. If I am a small business or a large business and I am losing my employees because they are carers to take care of a seriously ill older relative, that really matters in terms of my productivity and bottom line. And that's only going to get worse, not better. So I think what makes it different now than 5 years ago, 10 years ago, 15 years ago? I think there's momentum now that hasn't been there before. I think that it is the opportunity to bring together a number of different constituencies that haven't been there before. And I think you're absolutely right. This just can't be something that says to government, you do this, because that's not going to happen. And I do think, I don't know the Canada Health Act, but if it's anything like what we lived through in the United States, which was Medicare, which was designed completely for an acute care system, it had to be fixed. There was just no way around it, and I think it's not an either or. It's an and. I mean, what right now can be addressed with tweaks and changes, and what's the long-term change that's going to happen in order for this to be a basically sustainable program.
Thank you. Excellent question. I'm going to go to, were there any other members of the panel that wanted to comment? Okay, thank you. So I'm going to go now to Tammy Moore from the ALS Society of Canada, another member of our steering committee, and then we'll go to some more questions from online.
Thank you, Fred. And I think when you asked us just before we took the break to think about people that you hadn't heard from, and I think we've now touched on it a little bit, but I just want to draw attention to it. So the ALS societies across the country provide support for people living with ALS in each of the provinces. And Dr. Williams, when you had mentioned yesterday about the system navigators, our organizations actually have paid members, so different than what you're talking about, Dr. Perceau, as far as volunteers, but we actually have paid staff that are going out and helping ALS patients who are basically palliative patients to navigate the system already. And so I want to make sure that we haven't heard from this group and that we are identifying that this is an important part, and not necessarily that we want the job because we'd love to have, it not be through charitable funds that we're doing this, but that's who's currently providing some of the system navigation for people living with ALS in a very specialized population. We're there on clinic day as people are getting their diagnoses and then helping them to access resources. But the other thing that we're doing is we're talking about moving palliative care home supports home. We need to ensure that the equipment is there as well, because while the Ipsos Reid survey showed 6 or 7% of people thought that NGOs should be providing palliative care, and I agree with that, the fact is that our organizations across the country are providing wheelchairs, ramps, stair lifts, hospital beds, lifts, basic small bathroom equipment, so that people can stay in their homes while they're navigating ALS. So I think it's really important that we remember the charitable sector that's involved in palliative care supports as well. And I would love to know if there's some research being done, because as I attended the Canada 2020 Health Accord Summit, it also wasn't, the charitable voice wasn't there either, and there are many organizations like ours across the country that are providing this critical care, and as government continues to pull back, we're now being seen as the primary source of equipment in Ontario for sure, and in other areas across the country, so please remember this voice too.
Thank you very, very much, Tammy. Any members of the panel wish to comment? And Deborah, I'm sorry, I know you're sitting over here, so if I miss you, stand. Okay, we're going to go back to Carlene for some further questions from the podcast.
We've had several comments related to ensuring that we're culturally sensitive and that we're paying attention to populations such as people with low health literacy. The question that I bring forward is what would a recommended approach to needs assessment and data collection be for various cultural groups that do not perhaps speak English or use computers?
At least one of you has to take that question.
That's a real tricky one, and I wear another hat in the School of Geography and Neurosciences that looks at urban quality of life issues. And we really try to target vulnerable populations living in Saskatoon, Hamilton, as well as Charlottetown. This is a piece of research that was funded through SHIRC. And the vulnerable populations were not only those who were living in, under the poverty line, but also new immigrants and new Canadians who were dealing with various types of health challenges. And so after a 3-year program of research where we evaluated using a mixed method approach these vulnerable groups, we came up with a number of different recommendations, one of which was to put in place this coaching model where we had established immigrants basically volunteer to assist in the mentoring, in the navigation, in the training and education around the healthcare landscape. And so it's really again more established immigrants helping the newer immigrants in managing these challenges. And so I think we could do the same in addressing the end of life and the palliative care needs of these particular immigrants, whether or not they know how to use technology, but certainly the language and the literacy around the healthcare system would be addressed. Thank you.
Thank you. Please.
I think that's a really important question, and I think from a public awareness assessment point of view, that really what you need to do is you need to see the local community as co-researchers, if you like. We talked a bit yesterday about ethnography, and we've talked today about the value of qualitative research. And I think when you're doing any sort of public awareness work or any needs assessment work in local communities that perhaps are unknown or don't use the usual types of media that some of us might be more comfortable with, then you really have to get inside the community and let them take the lead, do work differently. So you use participatory methods. And you build those sort of compassionate research methods that perhaps are more difficult and take a much longer time than we might always be comfortable with.
Thank you. Thank you, Carlene. So I'm going to go to Dr. Bryant and then go to Sharon Mathias.
Thanks very much. I just want to say thanks for the opportunity of pulling this group together, and to say I wish very much to the panel that you produce something useful for all of us to move forward as we sit around and watch something over which we have no control tonight, that you produce something that does give us more control over our future. So thanks for your work on that. I am mindful that we have a unique opportunity in front of us when we have the letter from the minister talking about this related to home care. I'm also mindful of the fact we've had a lot of good information on professional training, both in the hospital and for home care providers. But I am acutely aware that patients are most vulnerable when they're in transition. Either between the hospital and their home care and their regular life or in the diagnostic process, the transitions are the vulnerable points. And so, Fred, when you asked the question about are there groups we haven't heard from, something that occurred to me is I haven't heard anybody mention the word hospitalist. And I think hospitalists are increasingly a way that care is provided in the hospital. They don't see primary care, patients don't see primary care physicians in hospital, other than the hospitalists. You know, they could have a role of not only becoming adept at the basics of palliative care, but perhaps even being mentors for primary care physicians out in the community and how to do that. And I've not ever heard of any training requirements in that area or any initiatives in that way, and I just wondered if any of you had or if you thought it was an idea that had merit.
Good question.
Thank you for that question. Like you, I don't think, again, just understanding that there are literally 2 programs in the country that have any mandatory palliative care requirements, and both of them end in the word oncology. The hospitalist programs as they exist are, as you say, they're starting to fill a big need of people who are exclusively taking care of inpatients, and we know that is where the bulk of death occurs in Canada. So I think I would agree with you, particularly when you're looking at a relatively small pool of individuals who are delivering a proportionately large amount of the end-of-life care. I won't say palliative care, but end-of-life care to these patients. It is a great opportunity to do that. The problem is because it is an extra sort of tranche. It's an extra sort of segmented component of the healthcare system. It's going to be always an area that will be, again, harder to fit into the sort of bigger system, the issues of trying to integrate with upstream decision making or then to integrate it with other sources of care. But I think there is certainly some merit to looking at the growing number of hospitalist programs and specifically hospitalists as again, a small pool with a high proportion of end-of-life care being provided through them would be pretty ripe for training, I think.
Thank you. Dr. Williams?
Yeah, just another small comment. There's been some real interesting work done by Dr. Wendy Duckleby at the University of Alberta, looking at a patient navigation tool. And we did this via a larger program of research looking at rural and remote systems in managing palliative care research. And the tool is basically a file that follows, it's a binder that literally follows the patient, given that often in rural and remote geographies we have multiple transitions, many more than what we would have, for example, in an urban state. And what's interesting about the tool is it not only lists end-of-life wishes, but also all the contacts specific to the practitioners, you know, the pharmaceutical recipe and so on and so forth. So the patient and the family and the primary caregiver, for the most part, doesn't need to be repeating that case history time and time again. So certainly something to think about. Thank you.
Thank you. Sharon.
A question, but you asked for people who weren't or what we weren't hearing about, and I've been struck by the lack of voice of organizational design and management, but also governance of complex collaborations, that both in multiple organization collaborations need some kind of a governance structure, and that's one of the pieces of the puzzle. My question is for Dr. Brexel, though, that coming back to the first session that you gave where you identified the need to come at it from a population health and a community health perspective, that if you looked at the arc of the conversations we've had since then, are there ways that you would think about the frameworks and the programs in a different way that we're really grounded in those, that brought in the physical environment as well as community groups?
Well, you're right. We have been chatting over the past couple of days since that initial presentation, and it has given me an opportunity for reflection. And I think it's this idea. It's bringing together two lines of thinking, and it's this notion of a population health approach and this notion of community development. And I think when I think of a population health approach, what I'm really thinking about is recognizing the broad determinants of health. And also within that is also employing some of those methods associated with public population health in terms of epidemiology and really sort of which cultivates an evidence-based approach in terms of understanding the dynamics in a sort of a selected community and identifying in terms of what are some of the causes for chronic illness, mortality, morbidity, and also where the disparities may rest or reside within a given community. So a public health approach, I think, offers the tools to develop an evidence-based approach of understanding a community to develop a robust and responsive palliative care system. I think they're tools, and I think then there's the process, and I think the process speaks to a community. Yesterday I was talking about a compassionate communities approach, and I think that if a public health approach is a broad determinants of health approach, a community development approach is also a broad determinants health approach where it's intersectoral. So it's health talking to social care, it's talking to housing, it's talking to clean water, etc. And so I think a community development approach really speaks to mobilizing agents within a community to build capacity to develop a palliative care system which is responsive to the needs of that community. A public health approach provides the tools to diagnose and to navigate and steer that community. Okay, thank you.
Thank you very much, Dr. Brazil. We'll go to Anne Sutherland-Bowl, CEO of the Canadian Nurses Association and another member of our steering committee. Anne.
Thank you, Fred. It's a wonderful opportunity to be here, and my comments and question are for Dr. Barbara Passert. So thank you so much for talking about certification and the programs that are offered by the Canadian Nurses Association. We do have 20 specialty programs, and there's over 20,000 nurses who are certified in Canada, so that's the good news. The bad news, as what Barbara was referring to, is sometimes our numbers are diminishing, and it's difficult for nurses to assume certification, which is a high-stakes exam that requires preparation, time, and cost. So we did a number of surveys amongst all our certified nurses to say what would make it easier for you. And there were two main reasons that nurses weren't becoming certified. The first was that just the logistics. Our certification exams were written once a year across the country, paper and pencil. So we figured, well, we'd best get into the 21st century. So we have become computerized this year, offered in 55 sites over 6-week period windows. So we think we've addressed that problem. But the second problem is the cost of the exam. And where employers have in the past supported their nurses financially to take the exams, that is becoming more problematic across the country. So there's a direct relationship that's decreasing, diminishing, and where you see employers not able to support their nurses to take the exam, you see the numbers decreasing. So funding really does seem to be a challenge across the country. The next comment I'd make is that, as Barbara had mentioned, there's 400,000 regulated nurses in Canada across 3 regulated nursing professions: registered nurses, licensed practical nurses, and registered psychiatric nurses. And we also heard that all providers need some level of education and information related to palliative care. I think we have a huge opportunity with the learning modules and technologies that are currently available to identify those wonderful best practice programs and offerings, and work with our regulatory colleges to make make it a requirement for nurses to take these programs as a condition of re-registering, which we all must do as registered practitioners on an annual basis. My question for Barbara is, you talked in the home care sector about the vast number of non-regulated practitioners who are providing care. What do you see as the best way of providing information and content to that vast number and percentage of care providers that are providing care that are not regulated?
Yeah, I think there's a couple of practical steps that we can take. First of all, I think the move to register nursing care providers is a very good one. And so I know a number of provinces have moved toward that. I think continuing that process is a really good idea. The second thing is that, you'll notice that some of the ministries of health are now embedding palliative competencies within what they expect of the education for nursing care providers. And I think if there was a standardized set of palliative care competencies for nursing care providers that had been agreed to at a national or even a provincial level, then it's much easier for the ministries to embed those in those documents because they're there available for them. So I think those two things would go a long way. I also know that there are a number of movements, a number of very good projects going on throughout Canada to work with residential care assistants. So some very innovative work being done in terms of assisting them. I'm not sure that we know what all of those programs are, and so I think there is always a very, very helpful step in having people map some of those innovations that are occurring so that others can know what's happening, which I think will probably lead to your comment.
Okay. Thank you. We'll go now to Maria Judd from the Canadian Foundation for Healthcare Improvement, another member of our steering committee and someone whose support we've greatly appreciated.
Thanks, Fred, and certainly from the Canadian Foundation for Healthcare Improvement, we've really appreciated the opportunity to be part of the planning and the discussion, important discussion happening over the last couple of days. And I've been reflecting on the importance of the discussion around talking about what's needed in palliative care, and also then starting the discussion about how are we going to deliver on that. And the reason that that's been so top of mind is really, the mandate of our organization is to help identify, validate, and spread innovative models across the country so that we can start to move beyond being a country of pilot projects. And we've heard about a lot of innovative models and initiatives already over the last few days, and I certainly hear that in conversations with people across the country. So first I wanted to just share that we are working to develop, in response to Marcel Saulnier's comments at the beginning of the conference and also Jim's comments about the need to understand what's working in different parts of the country, to really evaluate those and their ability to improve the experience of care for patients and caregivers and quality of life and the value for money in those models, and to spread those across the country. So we're going to be inviting people to share with us through a call for innovations in palliative care in February. And just to be clear, this is not a research call. There's not a big grant associated with this. It's really an opportunity to hear from people across the country what's working well in your community and how can we assess what's spread ready and how can we build the supports to help spread that across the country. So I wanted to share that and also to invite thoughts or comments, reflections from the expert panel and the lay panel as we design that call, an opportunity to look at what's already working and how do we support the spread of that across the country. And Dr. Morrison, you I think made a comment earlier around paying attention to the methodology and the mechanisms of spread, and any particular insights from what you've seen in other countries would be really appreciated. Thank you.
So I would actually, this is a paid political announcement. The brother-sister organization to mine in the States is called the Center to Advance Palliative Care. That's run by my partner Diane Meyer. And CAPC has been exclusively focused on both technical assistance to spread palliative care in the U.S. and to identifying and scaling innovative models. And I would strongly encourage you to touch base with them because they have really looked specifically about how do you not reinvent the wheel. What are the models that work? What are the business plans that work? What are the marketing materials that work? What's the online education that works? And that has been incredibly effective in scaling palliative care in the U.S. So my immediate answer is to touch base with CAPC, cipc.org.
Okay, thank you, Maria.
I don't have a question, but before the break, you asked about groups who might not have been mentioned in this. And I have a list, and it's kind of, some of them are overlapping. But what I'd like to think is that a strategy that's developed coming out of this conference would be able to encompass all of these groups. And the specific groups I'm thinking of are the homeless, people with mental health problems, people who are incarcerated or in the prison system, people who are geographically challenged, and frail seniors, because I haven't heard any of those groups talked about in this forum.
Thank you very much. I think that's a very important and telling reminder to all of us. I have a few closing comments before we adjourn for the day, but just before I do, Mr. Chair, I just want to check in with the lay panel. Are there any further questions? Anything else we can do for you?
I don't believe so. We've been listening attentively and benefited greatly from the questions in the room and from the experts' explanations to those questions. I don't think, am I correct in saying we are, again, sufficiently suffied, sir, and we thank you all.
Thank you. So, ladies and gentlemen, just before we adjourn, I wanted to say two things. First, as I mentioned to you earlier, the St. Elizabeth Reflection Room, which is located on the 3rd floor, and there is a description of the Reflection Room project in your program, but given the privilege that we've all had today and yesterday to hear some very important information and perspectives, not only from our experts, but from our lay panel and from one another, particularly in the last hour. I'd invite you to take a look. I'd invite you to visit the Reflection Room. You can also visit it virtually at thereflectionroom.ca. Just a little bit about it. It's a project led by the research team at St. Elizabeth Healthcare, a national healthcare provider supporting residential hospice education and research. And they've obviously played a very large part in supporting this initiative, both through the steering committee and as a sponsor. The Reflection Room leverages the power of shared storytelling and experiential design to engage people in thinking and talking about the end of life. We are studying whether reflection and storytelling are positive for people who have experienced a death, and whether reading the stories of others helps in thinking about dying and death. So in thinking about the tremendous privilege that we've all had over the last couple of days, I'd invite you to think about not only visiting the Reflection Room, either in the hotel here or virtually, but in particular to think about what you might have to contribute to what I think is a very important goal for all Canadians, and that is in making the discussion of this issue, the issue of death and dying, more comfortable and, quite frankly, a normal part of discourse when we think about our roles as family members and communities, and our roles as leaders in the healthcare system. So I leave you with that thought. We're about to adjourn, and this, of course, concludes the presentation of evidence to our lay panel, who now have the very difficult job of completing their deliberations and developing their consensus statement, which will be read tomorrow as part of these proceedings. I just wanted to say, ladies and gentlemen of the panel, on behalf of all of us, and we'll thank you obviously again tomorrow, but how much we appreciate the work that you've done, the personal commitment that each of you have brought to this, and please, as you begin these final discussions, know that you go with the tremendous appreciation and the full confidence of everyone in this room and the people that have been participating on the webcast. So thank you very, very much, and I think we owe you an advance round of applause for what may be a long evening. And we will all be very interested to see what you come up with, obviously, tomorrow morning. So the program for tomorrow, there is a continental breakfast, which I believe is being served outside here in the lobby, beginning at 8 o'clock. At 9 o'clock, we'll commence, we're going to do the closing ceremonies for the conference first, and then we'll move at 9:30 to beginning the process of the reading of the consensus statement of our lay panel and the conclusion of the conference. You may find tomorrow, we're competing with another, I don't know, some other event that's going on south of the border, but we're hoping a lot of people are working hard on media coverage for the consensus statement tomorrow, and there'll be people working overnight on that as well. So don't be surprised if you see some media here tomorrow and some additional cameras. But tomorrow belongs to the ladies and gentlemen of the panel. Again, we wish you the very best, and ladies and gentlemen, thank you for your kind attention, and have a very pleasant evening. Good night.